Good morning, everyone. Welcome to today's webinar by the CariFree Cooperative. I'm Sharon from CE Zoom. I want to assure you if you're watching right now, you will receive credit. You will if you haven't registered on CE Zoom for this course yet, you can register after the course with the link that Miss Jenny has emailed you. If not, I will put it also in the chat for you to be able to register on CE Zoom, and that's how we get our certificates. So after this course, at the end, we will display a verification code, and this is the code you'll enter on CE Zoom next to the course. And after that, you'll take the survey and your CE certificate will be in your records. And I'm going to turn the time over to Miss Jenny and Miss Laura, and they are going to introduce our speaker for today.
Thank you, Sharon, and thank you everyone for attending today's webinar. This webinar, like Sharon said, is sponsored by the CariFree Cooperative. And the CariFree Cooperative is a cohort of like-minded dental professionals who are working together to further the message of risk assessment, preventive dentistry, oral and overall health and wellness. Our presenters today are Kandra Sellers and Dr. Kim Kutsch. And here is Laura Moriarty with our first introduction.
Thank you, Jenny, and good morning, everyone. It is my pleasure to introduce Kandra Sellers. Kandra is the creator of Pristine Interprofessional Academy that focuses on collaboration between dental and medical professionals to not only increase the quality of patients' lives, but to save lives. Early in her dental career, Kandra had the opportunity to be mentored by specialists that drove her passion to the oral systemic connection. And it was through the work with the Academy that Kandra saw the opportunities with dental medical billing. Kandra has become well known and widely respected as an industry-leading speaker, educator, and coach. And we are so excited to have her here today. Thank you, Kandra.
Thank you. Let me just get my screen up here to share with you all. Just takes a minute here.
Kandra, can I
Yes.
just say something real quick? I just got off the phone with Dr. Kutsch, and believe it or not, there is a bit of bad weather where he's at, and they just lost power. And so he's going to log in on his phone. So you'll notice that we did lose him, and he's going to log in. And do you mind if I I apologize because I was on the phone with him. I didn't hear exactly where we left off, but I know I didn't get to introduce Kim. Do I have a minute to do that?
Absolutely.
Oh, okay. Okay. So along with Kandra, we do have and will have Dr. Kutsch joining us. He's a retired dentist of 40 years. He is a prolific writer, thought leader, inventor, and researcher in the field of dental caries and minimally invasive dentistry. He acts as a reviewer of the Journal of the American Dental Association and Compendium. Dr. Kutsch is the CEO and founder of Dental Alliance Holdings, the manufacturers of CariFree, and is a scientific advisor of dental caries at the prestigious Koi Center. We are so fortunate to have him as our fearless leader. Please help me in welcoming Dr. Kutsch. And so hopefully he will be able to log in momentarily with us all. So I'll hand it back over to you, Kandra.
Perfect. Thank you. Thank you all. And a special thank you to CariFree, Jenny and Laura for making this all happen, as well as Dr. Kutsch as well. Sharon as well with CE Zoom. I didn't put your logo up there, but I should have. I apologize for that. Without them, we wouldn't be here today. And I'm super excited to share with you guys some information that can hopefully move our profession forward. If you don't get anything out of this presentation today, the one thing I do want you to take away is this, that dental insurance should be looked at as a supplemental insurance. It's truly a benefit policy, not an insurance policy. And we need to start segueing into more things going to medical and looking at dental insurance or dental benefits as truly supplemental to medical insurance plans. So that's my one huge takeaway. If you don't get anything else out of this, which I would be surprised if you don't, but We need to start looking that direction. We're being forced that direction actually by a lot of the medical carriers to start submitting to medical. A little bit about my journey. I am a dental hygienist. I no longer am able to practice clinical hygiene and have ended up here. My path has finally led me to medical billing. I love it. I think the biggest thing that I miss in clinical hygiene is working with our patients and being a true advocate for them. And that's my center, that's my core of why I do what I do. This is from a patient of mine that I helped early on in the years, and she wrote me a fantastic testimonial that I could share with my clients and potential clients. I think it's really important for us to always keep at our core what's important. And for me, it's getting our patients the care that they want and that they deserve. And the rest of the production, the collections, I'm going to talk a lot about money today. All of that will follow when we do the right thing for our patients. And if we keep that, if we keep ourselves patient-centric. There is a huge divide between medical and dental, and our true collaboration with each other, as well as our thought processes about who we are in dentistry and the value that we truly bring to our patients and to our medical profession too. We should be collaborating more with each other. And unfortunately, there's still a huge divide here. I hope that in the rest of my career that I can move this forward and we can start closing this gap that's between all of us. Because our patients need us too. They need this collaboration to happen so that they can get the care that they want and that they need. I don't understand the divide when we look back at the industry, and we look at the Mayo brothers from Mayo Clinic. This is my home stomping ground. So I'm proud to say that in 1910, the Mayo brothers actually made a statement that there is a connection between the oral health and our systemic health. That was in 1910. We're at 2020, and we still have this huge divide between how we think when we go into a patient's mouth. And it's like we often think it stops at the teeth, which it's so far from that anymore. So we need to get past that point. When we look at overall, oh, everything okay? It just, somebody was unmuted. When we look at our bodies as a whole, it is an amazing machine. We pump more than 2,000 gallons of blood a day. We have 70,000 miles of vasculature. I mean, that's incredible. It's hard to even fathom for me that we can't think that there's a connection between medical and dental and what we do in this day and age and with the knowledge that we have. If there's studies out there that actually show that within 1 minute of an oral procedure, that the microorganisms are actually pumping through the entire body and have reached the hearts, lungs, and the peripheral blood capillary. Sorry, I can't talk this morning. It's hard to believe that anybody in medicine or even in dentistry still believes that there's not a connection. If the blood's coming out, the bacteria is going in. It's just that simple. So absolutely what we do impacts our patients' overall systemic health. In fact, that same paper showed that within 30 days of an oral procedure, that a person could have a vascular event, that we could have potentially created the issue. So we do need to move forward on this, and we do need to look at ourselves as medical specialists. We are a medical specialist of the head and neck. We're really no different than an ENT. And we need to start putting value on what we do and looking at ourselves differently. We are a medical specialty, and some people do look at us as that, but most do not. Most do not understand that we're not just dentists or dental hygienists. So I get asked this all the time. Are you sure we can bill to medical insurance? And we absolutely can. There's actually a law against discriminating against our provider type. So whenever we're having a challenge in a practice that I'm coaching about a payment on basic procedures that we provide. Medical insurance cannot not pay us for procedures that we provide every day, as long as they're medically necessary. That's a whole nother topic that we'll get into. So they can't not pay us on the medical side for procedures that we perform if they're willing to pay another provider type, because that would be discriminating against our provider type. And obviously we have to be practicing within our scope of practice. So again, dental insurance is a supplemental insurance, and we need to be looking at it that way. How do we establish medical necessity? Because that is going to be our key here. Everything we do has to be medically necessary. I often look at people's notes, and I often see that the notes show nothing about the procedures that we did and why we did them. That's medical necessity. We need to establish that, and we need to establish it using medical diagnosis codes. And that's something that, unfortunately, we have not been taught in dentistry, and we're not taught in dental hygiene school. Medical diagnosis codes for medicine, they can't give you even a prescription without a medical diagnosis code. So this is something this is the biggest gap right here in our industry in dentistry. We don't know diagnosis codes. That is really our golden ticket to everything that we should be doing, or everything that we are doing, and everything that we do when it comes to billing. Even if you're not medically billing, we should be using diagnosis for our dental treatment. If you ever get audited and your treatment is not showing medical necessity, you're going to pay a whole lot of money back. So we need to start understanding what this concept is of diagnosis. And we can't complicate it. Medical necessity is just that we are providing services and treatment to prevent, to diagnose, to treat injury, conditions, diseases, symptoms. That's all it is. It has to make sense. The treatment that we're doing has to make sense while we're rendering it. These diagnosis codes are formulated by many different organizations, just like we have the ADA. So there's actually more than 72,000 diagnosis codes. So just about anything that you want to find a code for, you're going to be able to find a code for that. If you can't in 72,000 codes, that's kind of crazy. Sometimes we have to dig for them a little bit, but there are 72,000 of them. So anything that we have in dentistry or any condition that we come across, there's definitely a diagnosis code for it. We want to key into some things. Pain. Does the patient have pain? I think we are so used to seeing patients that have pain. It is the norm, but we don't always document it. We don't always document that they're coming in for an emergency. We also see a lot of patients that have cancer or trauma. They can't function. They can't even masticate because they have pain, or they're losing all of their teeth because they've had cancer treatment. There's sleep issues, bone issues. Xerostomia is another big one. We see patients every day, all day long, that have dry mouth, yet we don't document it. Again, because I think it's just the norm for us to see these things, and we just get complacent about it. Do they have sinus issues, or is there a sinus defect or bony defect? We also need to look at the medical history and the systemic conditions. When we look at diagnosis codes, this is one site. I want to give you this tidbit that you can start digging in and looking for diagnosis codes, icd10data.com. If you just put into the search bar different things that you're looking for, you'll be able to find the diagnosis codes. If you just put in a hygienist, you want to put in periodontitis, you'll see that there's multiple diagnosis codes for that. One of the big ones that I deal with, this is actually a patient that we did a surgical treatment on for grafting and implants. Obviously, the top CT is severe atrophy, and the lower is severe atrophy of the mandible. So maxillary mandible atrophy, severe. This is what the diagnosis codes look like for that. If you type into that search bar for icd10data.com, you'll see these codes and that exact definition to those codes. And that's what would allow us to get paid on the medical side for grafting. That makes the grafting medically necessary. I mentioned many times, systemic disease and the effects it has on our whole bodies as a whole. And we need to start looking at that more. It's when we look at medical reimbursement for the procedures that we provide, it's not necessarily about the teeth. Sometimes it is, but not always. In this situation, this is a patient of mine, Brad. While this is about his teeth didn't get to this position in this situation without a medical condition that caused it. Brad had multiple medical conditions that caused severe erosion of his teeth. He was at risk for extraction of these teeth. He probably would have ended up in the hospital. And we were able to get all of his fixed prosthesis, which would be a crown. That's the term that we use in medical, is fixed prosthesis. We were able to get gingivectomy and crowns and core and buildups for all of these teeth. And now Brad can eat. Brad was just a little side story on that, because this is the impact that we have on people. Because of Brad's medical conditions, he and his family have a significant amount of medical costs every year. Brad wasn't supposed to live past the age of 9, and he was 21 in this picture. So he finally had gotten off of a feeding tube, but had nothing to eat with. Having actually something to eat with, his final prosthesis, I mean, what a difference. It was one of those cases, it made us all cry to see him be able to finally eat, and at 21 years old for his first time. All right, claims are not going to get paid without medical necessity established. So if there is not a diagnosis code on a medical claim, it will not get paid. It will not get covered. It will get denied every single time. Probably won't even make it to review. It'll probably just get shredded. So medical necessity needs to be established with diagnosis codes. I want to bring up something, deductible, because most people on the line, this is like the number one question, deductible. Everybody has really high deductible plans now. That is true. What I can tell you is deductible is simply a word. It doesn't mean that all procedures are going to apply to deductible. I can surely tell you that when you call an insurance carrier and you start asking about benefits for certain codes that we're going to render services for, they will always tell you after deductible is met, this is how we pay on that code. It doesn't mean that it's going to apply to deductible. I have many examples where it doesn't always apply to deductible. It depends on the patient's quality of their policy. And deductible is not something that we can control on somebody's policy. We really don't know until the claim has been processed. So here's a great example. This is the same, I'm going to show you 2 slides. This is the first one, and it is for diagnostics for sleep apnea, for screening for sleep apnea. And you can see what was billed and paid. You can also see that nothing went to the patient's coinsurance, nothing went to deductible. Now, this patient did have to pay some coinsurance on these particular codes, but this person did have deductible still remaining that she needed to meet, and nothing on this went to her deductible. This is the same patient, same date of service, her home sleep study. That went to deductible. So it's a perfect example of not always do the payments get applied to deductible. So that is a myth. So what can we bill to dental insurance? That's always the next question. Our exams, our consults, our radiographs, CT absolutely can be billed. And exams, I'm going to talk a lot about exams because that's our big our big one. Every exam that we do can be billed to medical. Trauma, we used to think that trauma trumped everything, but unfortunately there are some policies that exclude trauma, which is insane to me. the fact that it's excluded when it's kind of a catastrophic event sometimes, and that's why we have insurance, but it does happen. Surgery and the surgical things that go along with the surgery. So if they do approve a surgery, or if they pay for a surgery, they'll pay for a surgical guide or stent. They will pay for an interim prosthesis. And sometimes they'll pay for that final prosthesis as well. It just depends on the situation and the patient's benefits. They'll pay for a CT to plan the surgery. They'll pay for a CT the day of surgery, and they'll pay for a CT 91 days after surgery to reevaluate the healing, to assess the outcome of the surgery. So huge opportunities there. Appliances and durable medical equipment. So TMD, sleep are big in the DME category, durable medical equipment category, and those are covered by medical. Recently, I just got my Perio Protect, my own personal Perio Protect trays as well. So that was pretty cool. But appliances are absolutely, those things are absolutely getting pushed to medical billing versus dental benefit billing. So appliances. Let's look at evaluations. I know many people were on this webinar because they wanted to hear a little bit more about this. This is what we have to get away from. It's really hard. This is Jack. It's really hard to not look at Jack's teeth. And if you're a hygienist, you know that there's a bunch of calculus there and you want to clean it off, but you know those teeth are going to start flapping in the breeze when you do. We need to get past looking at the teeth. We need to look beyond the teeth. We need to look at the bone. That's what medicine's going to pay for. So it all starts here. It all starts with our evaluations. Dentists, well, in medicine, they're paid to think. Dentists should be looked at. That's what we should be looking at as well. We should get paid to think. A couple side notes as far as procedure codes and diagnosis codes, all the codes that we were talking about earlier, those all have to be picked by the doctor. Staff can't do that. But obviously we can certainly help coordinate that care. Dental is really limited by our codes and by our payments. Medicine, we get paid on the complexity of our care, the complexity of our evaluation. So in dentistry, I think of our recall exams because that's the majority of our exams in the dental practice. Is it different when we see a patient that's 10 years old versus a patient that's 80 years old? Absolutely. That whole everything about it is different. So in dentistry, do we get paid the same amount? Whether it's a 10-year-old or an 80-year-old, yeah, we do. We get paid exactly the same amount. It's very limited in how dentistry pays. We get a benefit for a 0210, and that's it. So in medicine, we get paid on complexity and how much we have to think about the patient's care. So what does that look like? Key components to evaluations, and this is going to change in 2021, but right now this is what we have. So based on the patient's extent of their history, the extent of their physical evaluation, the complexity of the medical decision-making. Secondary is counseling, so oral hygiene instruction, or maybe sleep apnea counseling, whatever it might be. Do we have coordination of care with another specialist? And occasionally we can factor time into that. That's how we're based in, that's how we are paid, and that's how we process through a medical evaluation. We're doing all of these things in dentistry. We're just not getting reimbursed for it. We have a lot of tools in our toolbox, and we have a lot of things that we use when we're doing an evaluation. I think we're probably the only profession that spends like an hour with our patients for our recall visits. We have a lot of tools that we can use. The first thing that I would be looking at changing in a dental practice would be your medical history. We need to have a review of systems. Anything that's generated out of the dental softwares is typically going to be very limited in the crossover into medicine. So I would definitely look at incorporating a review of systems, more of a medical type history, so that our patients start getting aware that the things that are going on in their body are affecting their oral health, and we need to know that. Blood pressure. We learned this in school, but many practices have stopped taking blood pressure. Because our patients see us more than they see any of their medical professions, this is one thing that we can do, one that'll impact our outcomes with our patients, but also to screen. We can save people's lives by simply taking a blood pressure. This should be being done, especially if you're going to be billing your exams to medicine. What about sleep apnea? Sleep apnea. There's so many people that have sleep apnea. We should be screening for this. We can make a difference. This is something that's so easy to do in a dental practice, and it's actually, it has been put on us to be the ones that screen for sleep apnea. The ADA has said, they've made a bold statement about that. You guys need to screen for sleep apnea, yet it's getting missed every day in our dental practices. But this goes into our whole exams. The more comprehensive our exams are, the more that we can get paid. To me, it's like we're working smarter, not harder. And we're able to pull out these tools in our toolbox and help our patients be healthier. This is an Epworth score. This is a super easy, basic way of saying, hey, does this patient have potentially a sleep issue? You could give this to every single patient. It takes a few seconds. It really takes no time at all to screen for this. What about diabetes? We have new codes in our ADA code book for diabetes and A1C. We absolutely need to know if our patients have diabetes. I think there's a lot of treatment happening out there, surgical treatment, without really knowing if the patient is pre-diabetic or not. We know that 95% of diabetics will have some type of periodontal disease. This is a big one. Does this affect our complexity of our treatment? Yeah, it does, absolutely. We know that patients that are diabetic, they will have a hard time controlling their periodontal disease. If we do surgery on them, they're going to have impaired wound healing. You're going to see implants fail. You're going to see infection. We need to know if they're diabetic or pre-diabetic, because it is going to affect every one of our patients that have it with their patient outcome. Let's look at, this is another thing. We may be providing multiple things to try to help with caries control. Yet we don't even ever do an assessment. How do you know if a patient is low, moderate, or high caries risk at all? What's your guidelines on that? Are you even assessing it before you are offering them a treatment like fluoride treatment, a fluoride varnish? That's one reason I've taken on and aligning with CariFree. I love the fact that they have measurable ways of doing this. They're looking at individualized therapy. I think that's really important. We need to slow down. We need to look at the patient in front of us and what is it that this patient needs. I think sometimes we get so systematic in our approach that we're not looking at individualized treatment. So accurately being able to diagnose, being able to give individualized therapy and have the best treatment outcomes for our patients. That's what this is all about. They have different methods and tools. So talk about tools in our toolbox. They have different tools to help with this diagnosis. And this is where we should be. We need to be assessing every single patient on caries risk. Again, targeted therapy approach. What does this patient need? They have anything and everything that'll check off the box for your patients. We need systems. Systems work. And we need products that are going to work and that have been proven to work on our patients. Caries and diagnosis. So if we are going to submit caries treatment, we need to have a diagnosis to go with it. And these are the 4 diagnosis codes that we can use on a claim form to help get our claims paid for. Makes sense. I'm hoping Dr. Kutsch is going to come in with his great.
Yep, I'm here now, Kandra.
Because I love your story on this.
You gotta love all this technology, but in the middle of a winter storm, as it started, my power went out. and having to get everything reset, I'm back, hopefully. But, Kandra, I think I was able to watch quite a bit of, almost all of your webinars so far on my phone. I've obviously seen you before, and I know you, and I think you are a superstar. But I think one of the things that, even like the one X-ray, Brad or whoever, you look at it, and as a dentist, I just look at that, and I'm looking at the teeth, and I'm looking at the bone loss, and we're trained to look at teeth. And physicians are trained to look at people, right? And I think that we need to, when we come to caries diagnosis, we always get looking at the teeth, and we want to look at the cavities and how many cavities do they got and how are we going to restore them. And we think that way because that's how we're trained. And we really need to step back. This whole risk assessment is us stepping back and going like, why does this person have cavities, right? And if we can get that part right, then we have an opportunity to actually help them become healthy. And if we don't ever answer that question, they will never be healthy. They'll continue to have tooth decay. And I think one of the biggest challenges that we have is we're trying to look at teeth, and then we're paid for doing procedures on teeth. And rather than making a diagnosis, and I actually, I've shared this with you, but I actually wrote John Featherstone and I wrote the CDT code for caries risk assessment. I think that was back in, oh man, it's been a while, maybe 2010 or so. And I actually got to testify to the ADA CDT committee. And we had written one code, and they came back and said, wouldn't it make more sense if we had 3 codes, one from low, moderate, and high? I said, oh, that would be awesome. Like this would be, I'm testifying before this committee, right? And that would be great. It'd be like diagnostic codes. And the line went dead. And it was like this morning, I thought I'd literally lost my connection. And there was silence for like 15 seconds. And I'm trying to figure out, what's wrong. I can't, and finally I'm like, is anybody there? Is anybody there? And they go, Dr. Kutsch, we do not have diagnostic codes in dentistry, and we are never going to have diagnostic codes in dentistry. And I just sat there just stunned. I thought, yeah, that's exactly what the problem with our profession is. We don't have diagnostic codes because we need those. Because then it's like, then once you made the diagnosis, then it's like, after that, everything else falls in place. Like the whole regimen of options for treatment all come back from the basis of your diagnosis. And if you don't have the diagnosis, we're just doing these, hit and miss shots out there at the patients, and it's crazy. But anyway, that's what. So I think I love what you're doing, and I thank you for sharing it with us.
That just almost leaves me speechless, because until our industry changes and starts utilizing this information more, it's gonna be me out there by myself trying to push this forward. On the ADA form, on the claim form, there is 4 spots for diagnosis codes. But that's really great, but nobody knows what to do with those 4 spots.
Well, we don't have any codes. Well, we don't have any dental codes to put in there, right? And so what we need to do is use these medical codes. And Kandra, what we need to do is Jenny and I know we're all on this webinar. Our team really needs to encourage all of our CariFree tribe to start using these diagnostic codes routinely, because the more that we use them, the more that will affect change long-term in our profession.
Yeah, and that's where it has to start, but it also has to start with our big organizations helping create this change too. And unfortunately, there is no dental diagnosis codes. They're all medical diagnosis codes. There's no such thing as a dental diagnosis. But, I do have one practice that was having a hard time getting some treatment covered. And I hear this all the time. Well, they want x-rays, they want intraoral photos, they want this, they want that. It's because they don't know what you're trying to do. Why are you trying to do the treatment that you're trying to do? They don't, it's the diagnosis codes that have to tell the story. So they actually, because they've been trained with me on how to do medical billing, they started plugging in the diagnosis codes, and lo and behold, their claims went through. They got paid. And I don't know that that'll be for every carrier, because I still think there's going to be a gap on the dental carrier side, what to do with those codes if they do come in. I'm not sure they're going to understand them. don't know, but it would sure be worth a try.
Well, thank you.
So, yeah, absolutely. Thank you for chiming in with that story. It just boggles my brain. This is what it looks like, guys. I know most of my doctors that I talked to one yesterday, and I said, how much do you get paid for your evaluations on average? And it's I usually get a response of, well, we get paid $20 to $30, maybe $40. This is an evaluation on the medical side, along with an orthopanogram as a Panorex. The patient needed a CT and a CT interpretation that was sent out. This is what was paid. This is what was billed. And of this, only $62 did not go to, was not allowed and wasn't paid. But you can see that this is a little bit different evaluation. Do you think that we could slow down maybe long enough if we got reimbursed like this? I don't know any MD that's going to be reimbursed $20 or $30 for an evaluation. It's just not going to happen. And how many of these things are we giving away because we're really brainwashed by what dental provides for our patients and how limited it is, what they do provide. But this is what it can look like on the medical side. This is a game changer for a dental practice. Let's look at opportunities just with evaluations. Say you do get that $30 and you have 1,000 exams that you're billing out. $30,000. This is what it looks like on the medical side. If you change your mindset, you change your fees. Really, the fee only affects your cash patients. This is what it can look like on the medical side. Would that be a game changer for you? I think for almost every dentist, it would be. This is working smarter, not harder. We can also look at retro billing for practices. This is a great opportunity. Most carriers will allow claims to come in up to a year from the date of service. So what I often do with practices, especially when they're learning this process, is we bill out to medical secondarily. And you can see what was paid on the dental side, then the medical side, and the total. Now, typically the write-off for this would have been huge if we would have just been going to dental. But you can see that that gap closes when we're able to collect from both places. These are both private policies that the patient's paying for. This would be no different than, say you were in an auto accident and your auto took over the coverage for all of your expenses. You go to auto, and then secondarily, if they don't pay for everything, you go to medical. And if you had some type of dental trauma in that, we'd go to dental last. So that's how this can work. We're writing off a lot of things, partially because of our mindset. We're afraid to even bill the patient because we don't think their dental is going to cover. So let's talk about diagnosis as far as imaging, because this is a huge one. This is one thing that bothers the heck out of me, Panorexes. We're dictated, if we allow insurance, dental insurance, to dictate our care, we are dictated that we can only take either a PAN or an FMX every 3 to 5 years. Now, we all know that they're completely different radiographs. They completely show different things. What if a patient came in and we only took FMXs every 3 to 5 years and we never took a PAN? What if we miss maxillofacial cancer? That's on our watch that we've done that. So is it best to only take one or the other? Or are we best to take both frequently so that we can screen for maxillofacial and oral cancer? That's how we can get this PAN paid for, is by taking it to medical and submitting it through medical insurance with the diagnosis codes of maxillary cancer and oral cancer screening. It's that simple. Let's look at this x-ray. Does this x-ray look normal? It's absolutely not normal. You see that radiolucency up there. So we need to start looking at this differently. A PA, typically they'll only pay for that with trauma. It looks at teeth. Yeah, we can see the roots, we can see a little bit of the bone, but it looks at teeth. We have an abnormal radiographic finding. We need to further diagnose. We can go to a pan, we can go to lateral cephs. If we see an abnormal radiographic finding, we need to move to a CT. Yesterday, talking to a doctor, you know, his thing was, my gosh, I got a CT. I had no idea. There was so much that I'm potentially missing on 2D. And a lot of my providers will say that. And they're like, can we take a CT on everybody? Well, you can, but that doesn't make it medically necessary to be billable to medical. Are you going to find a lot more? Yeah, you are. But that's the sequence. If you go into your MD, say you have a broken arm, or yeah, say you have a broken arm and you fell and you had some serious trauma to your arm. They would do a 2D radiograph, and then they would send you to an imaging center if they saw something abnormal, or if they wanted to look for tendon tears and things like that. So that's normal in medicine. What's not norm is for medicine to recognize that we have CTs in our offices. We have so much equipment in our offices. We're like, we have everything. That's why our overheads are so high. And I often see all these CTs getting written off because doctors are afraid to charge for them, or they don't know how to charge for them. Again, dental typically is not going to pay for a CT. It's very rare I see dental pay for a CT, but we can submit those to medical as long as they're medically necessary. And we start with an abnormal radiographic finding. This is what that can look like. This is actually a CT was submitted along with an interpretation. This CT, the provider had just gotten her CT. She wasn't sure about what she was looking at, so she sent it out for interpretation. The first diagnosis code was abnormal radiographic finding. And then you can see there was a bone density issue, cyst of the jaw, and then some chronic diseases of the tonsils and adenoids. That was on the report. We used those codes to submit for payment on this, and we're paid actually 100% on this claim. That's what that can look like. There's the check. That was here in Illinois. So diagnosis absolutely leads to the treatment. We've got to look beyond the teeth. Obviously we need to take care of the teeth as well, but when we're billing to medical, unless it's a systemic problem that's caused the problem, like Brad, you're not going to get them to pay for teeth very often. So here's Jack's picture again. When we look at diagnosis codes, here's a bunch, just food for thought. Does he have disuse atrophy? Does he have pneumatization of the sinus? I mean, he's got a whole bunch, aggressive perio, embedded teeth. There's probably a whole list that we could put on there, but that's just some of them. So is that medical or dental anymore? To me, I can look past the teeth, even as a hygienist, and I can look right at the medical issues that are there in front of us. And I guess, obviously, if he has a history of smoking, did that contribute to the loss of his teeth? What other medical conditions does he have? That's where our medical history is really important as well. So looking back at this x-ray, what about if we start to look at this as this is an infection of the jaw? That makes more sense to me. But I think we're so used to realizing that it's an abscess tooth, but really, unless you take a CT, you don't know if that's truly an abscess tooth or is it something else up there, because you don't know how deep that lesion is. This is a 2D flat image. So we need to look beyond. We need to be taking CTs of things like this, and we need to make sure that it's not impinging on the sinus in this particular case, or maybe if it was on the lower, is it impinging on the nerve canal? But we need to, this isn't just an abscess tooth anymore. This is an infection that's streaming through the patient's body. And what I know from research that's being done, 50% of heart attacks are due to an oral infection, whether it's an abscess tooth or it's periodontal disease. So do you think maybe that this is one place that medicine will pay for all day long? And here's what that looks like. Most practices that I start working with, when that patient shows up that I just showed you, They don't bill out an exam because they know that dental's only going to pay for a couple cleaning or a couple exams a year. And now I'm hearing that some of them are cutting back to one time a year. They often take imaging and they don't always bill that out. They basically bill out for the extraction at a couple $100. What about if we start looking at this and building value on what we are doing? Are we doing a cyst removal? Most likely, yes. Would we take an exam and not bill for it? What about if we bill that out and then we take a pan, we take a CT, we take a, we do a cyst removal, and in many cases we do a bone graft, but we charge out $300 for this visit. That doesn't make any sense. I'm not even sure how dentistry survives on their reimbursements that we get from dental and all the things that we write off. It would be really interesting to actually track all of the things that we perform and give away for free. Game changer when you can send this to medical. Here's just an overview of what I see as far as, this is a surgical case of procedures paid on the medical side versus the dental side. Now, what I know about dental is that they give us a great fee schedule and it has fees in the fee schedule, but they often don't even pay for those. So in this situation, dental, well, I put down here $8,000 that they would pay. However, they're never going to pay for that in a year anyway. So this becomes a 5-year treatment plan for the patient to get back to health and get back to being able to function again. It's totally different when we start looking at the mindset of getting paid as a specialist and being reimbursed by medical. So ROI is absolutely there. How does that help us in marketing? So we're able to see patients that have medical insurance. Now, almost everybody has medical insurance. The patient with the abscess tooth, I think that's one of the biggest opportunities that we see all day long. And it's recognized in medicine that this needs to be fixed when there's an abscess in the jawbone. I also know that a lot of patients in that situation end up at the hospital with a toothache. The hospital doesn't know how to treat them, doesn't want to treat them, and they refer them to the dentist. They didn't go to the dentist in the first place, probably because they don't have dental benefits. So what about if we work with our hospitals and say, hey, we're able to bill the medical now. Send them to us because we want to treat these patients, because what's truly happening is people are dying because of that infection. And I know that because I have a friend that's a transplant nurse. And she said, you can't imagine how often that happens. The patient goes away with their referral to a dentist, never goes, comes back to the ER and dies. It's something so preventable. Yet if we could just screen patients with a simple evaluation, a pan, think about the impact that we could make on people's lives. We could save people's lives. It's so simple to me. So, start working with your hospitals and your urgent cares about the services that you're billing to medical. Is that going to increase patients' acceptance? Hugely, yeah. Patients want a way to pay for this treatment. It's not that they don't want to do it, but when we give them a sticker price of $10,000 or more, how are you going to pay for that? We need to be the solution, and one of the solutions is through medical billing. I would consider going in network. If you are in network with dental plans, you should not be worried about going in network with medical. The fee allowances are so much higher on the medical side, and it makes it so smooth when you're in network. So those are all things that I would look at. That's a huge marketing opportunity to put out there, we take medical insurance. That gives people a way to feel assured that they can come to you to get treated. So we have a huge gap here. Again, over time, I'm hoping to close that gap. I'd love to help practices do this, closing the gap and getting patients what they really want, what they really need. Let's get people healthy. That's the whole goal here. So let's open this up for Q&A. I'm sure there's got to be some out there.
Oh my gosh, you are so right, Kandra. And thank you so much for such an amazing presentation. I learned so much and I want to listen to it again. We did get quite a few questions in, and I can just start at the top. And one of them, let's see, Arnell says, could you explain what the numbers past the period in an ICD-10 code mean?
It actually helps clarify. When you look at ICD-10, you'll often see there's actually a red triangle and a green triangle. If you have a red triangle, they need more clarification about that diagnosis code, and you have to explore that further. So often it'll say there can be multiple. You see this a lot with trauma. Well, you do with all of them. It'll specify like carries risk. There's moderate, there's mild, moderate, and high. So you'll see that there's more numbers past the period, the more specific the code is getting. I don't know if that explained it well.
That made sense to me.
Okay.
The next question is from Cindy. And Cindy says, I keep getting from medical insurance that no dental is a benefit. Do they ever make exceptions if it's medically necessary? And then she further continued with, I think what she did is copy and pasted something, a response that she got. And it looks like that these were all dental codes, D7953, D7952. And then it says, which would be covered at 60% after $2,000 deductible has been met. $0 have been applied toward the deductible.
So is that going to medical though? Is that what you said, going to medical? Typically, we don't send a CDT code to medical. We'd send a CPT code to medical.
That's what I think is the question. I think maybe the billing codes are not correct if you're sending to medical, correct?
Yeah, I mean, once in a while, like with wisdom teeth, they'll want you to use a CDT code, or sometimes with TMJ appliances, but typically you send, and sometimes with trauma, typically you want to send a medical code for medical reimbursement.
Mm-hmm. Okay.
Yeah.
And what I'm going to do,
they probably don't know what to do. They probably don't know what to do with that claim because they don't know medical, like dental doesn't know medical. That's just a communication. They're probably, as soon as that shows up on their door, they're thinking, oh, you meant to send that to dental.
Yeah. And what I'm going to do is I have copied all of these questions. So if we don't get to them, I'm going to email them to you, Kandra, so you can respond, and then we'll email them back to the person that asked. So
okay. That'd be great.
Let's see. If we diagnosed a patient with caries and source of treatment is restorative, can this be billable to medical?
Depends on the situation. If there's a systemic condition that's creating the patient's mouth to bomb out, we can sometimes get that covered through medical.
Can you bill both medical and dental?
Yes.
Awesome.
You can bill both. You cannot keep more than what you billed out. You can't keep a penny more than what was billed out. So you can get to 100% of what the data service was. You can get to 100% by billing to both medical and dental, but you can't keep any more than that.
We have a lot of questions coming in. So when you go in network, can you then pre-authorize like we do with dental?
Yes. Yes. Sometimes I would absolutely recommend that because you do want to try to get there. There are what we call global policies that medicine uses, and that's how they determine whether or not they're going to pay for things. And when it comes to dental type things, we need to have their eyes. I like their medical review team to get their eyes on what we're trying to accomplish and get a prior authorization for.
Here's a couple of questions. Where do you suggest we can get more information on how to implement medical billing in our practices? And how do I start with medical billing?
Well, you can contact me if you want.
That's why I asked.
I love talking to people about this because again, for me, I hear all the time, we've tried this, it doesn't work. My practice is if they listen to what I'm coaching them on, they will be successful at this. I have no doubt about that.
Yeah.
It does work. It does absolutely work. But is it a process? Yes. Is it a tough road? Yes. But you have to look at the big picture. If it takes a year for your practice to get this all in place and running smoothly, the first 6 months are the toughest because you will get those claims coming back saying we don't pay dental for this. That's a bunch of hooey for starters, if we're doing things right. But those 6 months, they will push when they first see that MPI, that dental practice coming through, they will push back with every tactic I've ever seen. And you need to know how to push that back to them. So the first 6 months are tricky, and then it starts to smooth out and it starts to get easy peasy. It's a year out of your entire lifetime of your practice, sometimes more depending on how many procedures you're doing that we can build a medical. So it's a process, but you need to want it, you need to be willing to invest in that process.
Philip is asking, where do we get the forms to submit to medical?
They are CMS 1500 forms. You can buy them right on Amazon.
Oh, nice.
But you need to have a program to fill them out. So I have a clearinghouse that I can fill one out through Change Healthcare, or you can buy like a standalone program called Speedy Claims. And you still need to sometimes generate a paper claim, so you can actually get the paper claim form on Amazon. But Speedy Claims is a great way to produce the claim itself, really reasonably priced.
Let's see. There was a question here about emergency. Arnell, do we need to pre-D even if it's an emergency? And I apologize. Okay.
No. And even if you're out of network and an HMO comes in, often they will cover that. I mean, HMO is a closed network, so they can be tricky to work with, and will typically deny your claim first before, if you push it back, they'll usually pay for it when it comes to emergency treatment. And often prior authorizations, not only so typically they look at the claim completely different when it's coded in emergency. If it needed a prior authorization, they tend to overlook that. If the patient needed pain, I mean, that scenario with the cyst removal, the CT, all of that, those are a slam dunk. And they, like I said, they process it. They'll sometimes process it as an in-network benefit versus if you're out of network and without prior authorization needed. That really comes down to the quality of the patient's policy.
There's a lot of great questions here, and I think that you should be getting a lot of emails and a lot of calls and a lot of people interested in you helping them. Another one, and the last one, and then we'll wrap things up. What are the most commonly used diagnosis codes and CPT codes? And maybe that's a loaded question.
It is. It depends on your practice. It depends on what procedures you're doing in your practice. But I would say for sure the oral cancer and maxillofacial cancer screening. And then it comes down to the cyst removal, so infection of the jaw. And then I would say the atrophy codes for the arches for maxillary and mandibular. Those are probably the ones that I use the most and see providers use the most. Especially if you're doing surgical procedures, or if you have patients that are coming in with an emergency toothache like that, imaging type things.
All right. Well, it is almost 9 o'clock, and so we can go ahead and wrap things up.